Now that we've gone through the different types of synovial joints, we need to go through how they move. Now, a couple of these terms we've already talked about briefly when talking about the actual joints themselves and what the joints can do. But let's go through them, make sure we have all the terminology down and set to go for movements of synovial joints. First one up is flexion and extension. In the case of flexion and extension, it's looking at decreasing or increasing joint angles. So take the elbow, for example. If you're flexing, you're decreasing the joint angle. If you were to extend, you're increasing the joint angle. Do the same thing with the wrist. Flexion, decrease the joint angle. Extension, increase the joint angle. You can do the fingers, any of the synovial joints pretty much can have this flexion extension that move with decreasing and increasing joint angles. Abduction, adduction, and circumduction. So in the case of abduction, 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 that one you're moving away from the midline. So moving away from the midline. In the case of adduction, adduction, think you're adding together, you're coming back to the midline. So adduction is coming back to the midline. And it's not just with the shoulder. It could be the wrist too. Think about the wrist is out. If you go towards the body, that's adduction. Away from the body is abduction. You can do that with fingers, leg. Either way, it's still abduction, AB, away. Adduction, coming towards. So abduction away, adduction coming towards. Now, in the case of circumduction, this is not rotation, so it's something different. Circumduction is, you notice how it's shown here as a circle going around the wrist there. That's because in circumduction, you're not twisting anything. It's moving in the same plane like this. The palm is still the same direction. Circumduction. That would be circumduction. You're going around a structure. Circumduction. So abduction, adduction, circumduction. Now rotation. You can see here the leg rotating, the head rotating. The idea is as you rotate, it's twisting around one central point. You do not have rotation in your forearm. That's something different. So the forearm is not rotation. But the head, axis, atlas, rotation. You can rotate around the ball and socket joint. So the actual humerus here can rotate in the ball and socket. So rotation, spinning around that central axis. Gliding movements. When we talked about sliding joints before, gliding movements, they're simply going past. Your wrist, your carpals, they're all having gliding motions. They're just sliding past each other as you move around. So the idea of two flat bones sliding over. The idea of gliding movements. Supination and pronation. Now, this action is specific only to the forearm. In the case of supination and pronation, you can see from the diagram here, in the case that the two bones are parallel, this is the supine location. If the palm was to go and twist backwards so the palm is posterior, that is now the prone position. So what happens is the radius is actually going to end up coming over the ulna. So the radius up by the elbow stays intact. But down here, notice it starts out away from the body, so more lateral. But as you go through pronation, it becomes more medial, the radius. So the idea of supination, pronation, supination, pronation, only available in the forearm. That's it. Dorsiflexion and plantar flexion, specific to the foot. You're saying, hold on, they're both flexion. Very true. There's no extension of the foot. It's dorsiflexion and plantar flexion. In the case of dorsiflexion, you're lifting your toes up. So you can see here, dorsiflexion is pulling the toes up. While in plantar flexion, you're pointing the toes down. Plantar flexion points the toes down. So if someone's basically a ballerina or doing ballet on point, the toes are pointed down. So the idea of plantar flexion, you're planting the toes down. Dorsiflexion, you're pulling the toes up. Both of those are specific to the foot again. So dorsiflexion, pull up the toes. Plantar flexion, plant them down. Plantar flexion. Inversion and eversion. Again, we'll look at the feet. If you're going to invert the feet, inversion, you see here, the sole is being turned towards the middle. So if you're inverting this, your feet, you invert, the soles face each other. Inversion, soles face each other. While eversion, the soles are going out. So these are your feet. Eversion, the soles face outward. So in eversion, the soles face out. So the idea of inversion and eversion, as well as dorsiflexion and plantar flexion, are specific to the feet. Protraction and retraction. Now, in the case of protraction, anterior movement in a transverse plane. Retraction is posterior movement in a transverse plane. Transverse plane is like this. So you have the idea of the mandible can protract, the mandible goes forward, retract, the mandible goes back. And that's what you're seeing here. Protraction, the chin juts out basically. Then when you do retraction, the chin is pulled back a little bit. So protraction and retraction. You can also have the scapula protract and retract, moving along this horizontal or transverse plane. Protract and retract of the scapula there. A couple of special movements go through. Elevation and depression also. In this case, elevation is lifting up. Depression is heading down. You can see you can elevate the mandible, basically close your mouth. Depress the mandible, you open the mouth. Same thing with the scapula. Elevate, shrug your shoulder. Depress, goes down. So elevation lifts up, depression lifts the joint, pushes the joint down. So elevation, depression. Opposition. This is specific into the hand. Your thumb, referred to as the opposable thumb, can go through and be opposable to each of the 4 other digits. So the idea of opposition. Your thumb can wrap around and touch the other 4 fingers. Opposition. So a few different movements of how the synovial joints can function, how they can move. But each joint, as we already saw in previous videos, can have 1 plane movement, if that, or 2 or even 3 planes. So first off, that you have non-axial plane. That means there is no central point. It doesn't have to always come back to that central point. It can just simply go anywhere at any time. Non-axial. Uniaxial goes in 1 plane. Think of flexion extension. That's a uniaxial type of movement. Biaxial goes in 2 planes. When looking into the wrist, for example, depending on which joint they're looking at, a saddle or a condyloid joint, you have flexion extension as well as adduction and abduction. And then multiaxial means you have 3 movements. These are the ball and socket joints. You can have the flexion extension, abduction, adduction, as well as rotation. So as looking at the diagram here, you can see how A has multi-axial but a little asterisk. That's because that's down here in the wrist. Those are the sliding movements. It's referred to sometimes as multi-axial or non-axial because there really is no central axis. There's no central point that controls it. The uniaxial, we're up here in the elbow. For uniaxial, that was looking at the hinge joint, think trochlea and trochlear notch, as well as looking at the pivot joint. In this case, it's showing the head of the radius to the ulna, so it can cause pronation and supination. Then the biaxial, down here in the hand, looking at saddle and condyloid joints. So it has 2 different types of movements there. So looking at, for example, flexion and extension, as well as abduction and adduction. Think about the fingers that way. Flexion and extension, abduction and adduction. It's all based on how they're moving in two different planes. And then the last one is the true multi-axial. That's up here, ball and socket. So it can move three different planes. Multi-axial is three planes. Flexion, extension, abduction, adduction, as well as rotation. So if you look at the shoulder, flex, extend, abduct, adduct, and then rotation. So multi-axial for the ball and socket joints. But how do you keep all these joints together? Because any of these joints can have a problem, but you hope to keep them solid and intact. So first thing here is the shape of the articular surface. Now sure, when you think about the trochlear and the trochlear notch in the elbow, they kind of fit nicely together. But then think about your knee. The round condyle of the femur on the flat top surfaces of the tibia. You have ligaments there, you have all these different things helping out, but that surface is not really to keep it in place. So some joints have the articular surface really helping to hold together. Other ones need some helping hands, like ligaments, for example. The more ligaments you have, the more structural stability that's trying to be built into that ability. Because if you have one ligament, it's just a little bit holding together. But 2, 3, 4 ligaments, they can help to actually get more stability, more structure, because there's more strength in that actual joint then. And then add in muscle tone. Your muscles are going across your joints, across your articulations. That's how they move. The muscle contracts and pulls something across the joint. So as the muscle goes across, the more muscle tone or more muscle strength you have, that'll give more stability to that actual joint as well. So you're looking at the strength and stability of the actual muscle, the number of ligaments, the shape of the articular surface, all helping to provide stability and structural support to that actual synovial joint. Now sure, there's the synovial capsule, the joint capsule, but that only has so much structural support in the tissues there without looking at ligaments and muscle tone as well as the shape of the articular surface. So a bit about the synovial joints, how they move, and some structural stability there.